All right, we're going to talk about the normal newborn here for a little bit. Let me give you a forewarning. I have two dogs staring at me in my house, so if they start barking, I apologize ahead of time. We'll see how far I can get. Okay, the normal newborn. How does the newborn start to breathe? In utero, you know, they've been relying on the maternal circulation for its oxygenation, but now it has a big task of figuring out how to do that all by itself. And there's various stimuli, as you see written along the top of the slide here, that cause that initiation of the first breath. You have the chemical stimuli, which is basically your changes in your O2 and CO2 levels, and that pH level will drop, which causes that respiratory center in the medulla oblongata to realize it needs to breathe. As you know, increased CO2 causes that to stimulate that area, and the baby's diaphragm will contract and they'll take that first breath. There's also the sensory stimuli such as sound, light, smell, touch, unfortunately pain, yes. We're rubbing their heels, doing everything we can to get those babies to cry vigorously because that opens up the alveoli in their lungs and gives them a better chance at having a healthy first few hours. Thermal stimuli, of course, they go from that nice, warm, watery environment to cold. We try to keep the baby warm. That is goal number one, keep that baby warm and dry. But there is a change in temperature, so that's going to initiate some of that respiratory effort. And then the mechanical stimuli, that's if we have to do chest compression or actually, that is the vaginal compression that happens at the time of delivery. And if they get a C-section, they do not get that chest compression effect. And so it's a little bit trickier for the C-section baby to have a healthy initiation of respiration because of that lack of chest compression due to vaginal tightness. But they usually do really well. Indications for respiratory distress. What is it that you need to be alert for as the nurse in the room with the newborn? And that would be different types of respiratory behaviors listed here, grunting. I think I have some slides that I'm going to show you that are videos, and if I don't have them in the slides, I'll make sure to post them in our course den. Actually, I think that's where they are, is in our modules. But the grunting is kind of and the parents sometimes will mistakenly think that that's kind of cute because they're making that cute little noise, but it's not cute. It's grunting and it needs to be addressed and fixed. Flaring is the nasal flaring. You'll see them, babies are invariably nose breathers. And if they have trouble breathing through that nose, you're going to see the flaring of the nostrils. Retractions of the chest as they pull in, trying to take the deepest breath they can. The chest wall goes in. If they hold their breath, they have apnea for greater than 20 seconds. That is not good. And then, of course, the bradycardia or tachycardia. Check their pulse rate, of course. Labored respirations, they just look like they're breathing hard. And then cyanosis, of course, is the blueness. They don't pink up. And babies are not going to pink up immediately, but the center of their body should be pink. The hands and feet may stay bluish, but the central system should be pink. The tummy, face, unless they've had bruising from a fast delivery, then they'll have bruising on their face. Okay, the cardiovascular system goes through a lot of changes due to different pressure changes in the heart at the time of birth. As the lungs inflate, that causes a decrease in the pulmonary resistance, and the babies will get an increase in their pulmonary blood flow. Additionally, they get a decrease in that pulmonary arterial pressure and a decrease in the right atrial pressure, and all those closures, or all those pressure changes causes closures of these three, quote, holes in the heart that are normal during fetal period. The newborn period, these three will eventually close, and they must close to prevent permanent cyanosis, permanent stress for not having well oxygenated blood. The foraminal valley, we'll talk a little bit about on the next slide about these a little more. Your ductus arteriosus and the ductus venus are all necessary anatomical closures. They start closing within the first 24 hours, but it takes a few weeks for them to complete their full closure. If they don't fully close, that's where you get the heart murmurs. And usually in the newborn, those heart murmurs are transient, but every once in a while you have an adult with a heart murmur that just never closed, and apparently they're doing okay, didn't need to have surgery. This is how the fetal circulation terminates. That ductus venosus closes with the clamping and cutting of the cord, and that starts the process of increasing the atrial pressures. The foramen ovale will close when increased pulmonary blood returns to the left atrium and the pressure increases in that left atrium, and that permanent closure can take several months. The ductus arteriosus will begin to constrict as oxygen level increases in the arterial blood, and its permanent closure begins at approximately 3 to 4 weeks of age. So all that has to happen. It takes time, and I do have some videos that will demonstrate those that might be in my other set of slides, but we'll get to it. Don't panic. The hematology adaptation, the bone marrow is the major organ of our hematology. In utero, the RBCs will increase related to that low oxygen saturation. So because of the low amount of oxygen in that fetal blood, they'll have a greater amount of RBCs in utero. After birth, the RBCs will decrease until they're about 8 to 10 weeks of age. So initially, you're going to see an elevated hemoglobin in the newborn of 15 to 20, completely normal, as they needed more hemoglobin to carry oxygen when they were in the uterus. The crit, of course, will also be a little high, and the plates should be normal, and the white count should be normal. Thermoregulation is hugely important. Babies are not born with the ability to maintain their body temperature real well. And so, especially since when they come out, they're cold and wet, right? So we need to dry them off and keep them warm. Skin to skin on mama is the best. Mama's temperature at delivery is a little bit elevated, and that's a normal finding. And then we use that temp to keep the baby a little warm. You know, that's almost as good as the warmer, probably better actually. And our goal is to help them maintain their body temperature until they can do it independently. Their heat generation is from vasoconstriction, and their metabolic rate increases. And they have what's called non-shivering thermogenesis. When we get cold, we shiver. Babies do not shiver for a while. So if you see a baby that looks like it's shivering, that is not shivering. It's more like tremors, and we need to find out why it's having tremors. The most common reason for that would be low blood sugar, but that's another moment on another slide. Your non-shivering thermogenesis is accomplished by brown fat and increased metabolic activity in the brain, heart, and lungs. So that's how those babies are increasing their body temperature. They have more brown fat and the metabolic activity is increased. Heat is produced by the intense lipid metabolic activity. So basically everything is just going rapidly in that little baby's body, and that causes heat production. They have their brown fat located around the shoulders, the axilla, lumbar area, and kidneys, and it depletes very rapidly. So it's important that we promote environmental warmth so that we don't get them sick. The biggest thing to prevent newborn respiratory issues is provide warmth. Make sure they don't get cold. Cold stress is terribly difficult for a newborn to handle. They have a larger amount of heat loss due to the large surface area to body weight. They have less fat for insulation. A lot of them come out pretty skinny, except for the brown fat, which we mentioned, which is internal. They don't have subcute, that fat right under their skin. And then they have thinner skin than we do when they get older, and their blood vessels are very close to the skin. So that's where their heat loss mainly comes from, are those 4 areas. The effects of that heat loss is to cause an increase in demand of oxygen and glucose. So what do you think you're going to see? Of course, you're going to see an increase in respiratory rate because they need more oxygen. It's harder for them to breathe, and they have hypoglycemia due to that cold stress. The sugar, they'll use up the sugars that they do have, and you'll start seeing tremors. And in worst cases, heat loss may cause the neonate to revert to fetal circulation, and that, of course, everything backing up. No, that would not be good to have the pressures change backwards. Methods of heat loss for the baby, there are 4 different methods. First one is evaporation, which we've mentioned, and that's when the baby coming out of that wet environment is exposed to the air, which is not going to be as warm as where they came from. And so that wet body at birth will be a major reason. So that's why it's so important to just have a pack of dry blankets and keep drying, and throw those blankets off. Don't keep them on the baby, just keep drying and discarding until you have a nice dry blanket. Double wrap the baby so we prevent that evaporation heat or minimize it. Whenever we're bathing a newborn, we've got to make sure that it's done under a warmer light so they're not losing body heat after that. And babies don't need to be bathed right at birth. I mean, that's actually not contraindicated, but let the baby be with the mom, and that vernix on the baby is healthy for the skin. It keeps it from getting dry and cracked. So, just wrap them up, let them be who they are. But eventually the babies get bathed. Make sure we do it so that they stay warm. Radiation is transfer of heat to a cooler surface not in contact with the skin. So when you have a baby laying in an isolate or laying in their little crib, the walls of that isolate are plastic generally, and that can be a method by which the heat goes from the baby to those plastic walls. Also, if there's any cold object placed on an isolate or any equipment in the crib that's in there, that can cause radiation heat loss. And when I say equipment in the crib, we do glucose checks and that. Just even that little glucometer laying in the crib can take heat away from the baby. So we minimize the heat loss to radiation as much as we can. Conduction is where heat is transferred from the baby's body to a cooler surface through direct contact. That is what you would notice with, cool scales. When we weigh the baby, they're good. They go on the scale. We put a blanket on the scale to keep it from laying directly on the plastic or metal or whatever that surface is. So we do minimize that, but still being on a blanket that is on top of a non-heated scale will cause conduction heat transfer from the baby to that surface. So minimize that. Dads like to take pictures of the baby when they're on the scale to get the weight, and we strongly encourage that. That's a great thing, but let's make sure he's ready with the camera before we put the baby on the scale so that we can have that baby on the scale as short of a time as possible. Always warm our hands, warm water, whatever it takes to have warm hands when we're touching these babies. Blankets, we can put them in a warmer on the unit and use only warm blankets. Convection heat is that which goes off due to the air being cold, and that's why it's important to have the air temperature in the rooms not be too cold for the baby. That's something to assess whenever you're on postpartum, especially, is go in the room, make sure that it feels like a comfortable warm temperature. If it gets too cold, that baby's going to suffer. Okay. The liver is going to start producing coagulation factors. The complete production of those won't happen until the baby's a week old because of the vitamin K, as you know, doesn't get made until the gut is not sterile and has had time to make it. But the liver will start producing coagulation factors. Iron stores happen there, starts metabolizing carbohydrates, and the big one in babies is that bilirubin. Our goal is that the liver's ability to break down and excrete bilirubin keeps up with the amount of red blood cells breakdowns presented to it, because we don't want those babies to get jaundiced. Can become a severe problem, and that's a conversation at another point in time, but bilirubin is the biggie to watch for, because the livers can't keep up with massive needs for breakdown of red blood cells. The immature liver hinders coagulation, so that's why it's important that it starts taking over. Then the gut is sterile at birth, as we've mentioned before, that the baby is given vitamin K at birth because the body cannot make it yet until that gut has bacteria in it through eating, basically, because that's necessary for synthesis of vitamin K. So carbohydrates, glycogen stored in the liver converts after birth and before feedings are started to help support that newborn who no longer has maternal glucose coming at him to adapt to that transient before he's eating really well. He still can maintain his glucose level a little bit. When stressed, a neonate's unable to maintain the glucose level, and so anytime they have cold stress, they're going to burn up more of the glucose that they have, use it up more rapidly, and they'll get hypoglycemic very easily. The results of a low blood sugar, what you're going to see is if untreated, if left to its own device, you're going to see respiratory distress in these infants. They're going to get apneic, lethargic, tremors or convulsions. Tremors is what you're going to see first. The little hands go really shaky, shaky, shaky. And anytime you see that, it's time to check the glucose. Hypothermia, of course, they'll get unable to maintain their body temperature, the heart rate will go down, and of course, eventually death, but we're going to treat it before that happens. Their iron storage is usually sufficient from the mother. They have 80% of their hemoglobin is from hemoglobin F, which is the fetal hemoglobin, and that's good for the baby until it can get into the more adult type. But iron stores in the liver from the lysis of red blood cells, and again, there's that connection of the liver and the breakdown of red blood cells, and the liver needs to be able to handle that. Bilirubin, as you know, is the substance that needs to be excreted because if it accumulates in the newborn body, it can cause really severe problems. There are two types of bilirubin. There's the conjugated or direct, which are water soluble. They convert, the converted form will be excreted by the colon and the kidneys. Those are less likely to cause a problem. The unconjugated or indirect ones are fat soluble, and they are an unconverted form that's derived from the breakdown of red blood cells. And those red blood cells, as they lysis or break down, they produce a bilirubin that the liver is supposed to excrete or handle. But these little babies, their livers are not mature yet. And so babies with an excessive level of red blood cell breakdown will show jaundice. The babies at high risk for that problem are those that are premature, preterm babies, because their their livers are even more immature, less mature, so they can't keep up with the need. The macrosomic infants, those big babies that come out really fat, they have a lot of red blood cells, more than the non-macrosomic infant, so that the liver, even though the baby's bigger, the liver isn't, it's not any more mature, so it has a harder time breaking down those extra red blood cells, and they will get jaundice. We will talk more about the other babies that are at risk for higher levels of bilirubin, but you kind of get the idea that the more red blood cells or the earlier that liver is supposed to work, the less effective it is. The harder it has to work, the more likely the baby can have jaundice. And if it gets severe enough, they will get what's called kernicterus, which is really severe. It causes permanent neural damage to the central nervous system. So it's really important we prevent that. And it's easily treated. You just got to know what it is. Recognize that it's there. Their GI tract, they can ingest, digest, and absorb. They have been doing that, so they just keep on doing it. The bowel sounds can be auscultated pretty much right away. 1 hour of age, they should start having little bowel sounds. They're pooping, their peristalsis is uncoordinated for about 2 days. They have a really interesting peristalsis mechanism by which they just, all of a sudden, you will think they're not going to ever poop again, and it all comes out. It all works all of a sudden. So that's very unpredictable and can be quite amusing, actually, especially when the dads change the diapers. There's a gastric reflux that's related to an immature cardiac sphincter. And so as that baby's trying to eat whatever, whether it's breast milk or bottle milk, there's a reflux coming back up. And that can take a while for that sphincter to totally, when I say a while, it could take months for that sphincter to get mature and prevent reflux back up. Gastric capacity is approximately 30 to 60 milliliters per feeding, with increase to 90 in 3 days. It's about how much those little tummies can hold. Stool cycle starts out with this thick meconium. It doesn't have an odor. It's thick and sticky, very difficult to clean up. It contains bile, mucosal cells, hair, amniotic fluid, and it's passed within hours to 48 hours after birth. That's the first stool that the parents and you will see. Then they go into a transitional stool, which is slimier, thin, kind of brownish green, and that lasts for about 2 to 4 days. The stool cycle then changes into, they split based on whether they're breast or bottle fed. The breastfed babies, their stool is more of a golden yellow. And this term sweet smelling, I don't know about the sweet smelling, but it doesn't smell bad. It's just, it's just there. And that'll happen within about 4 days of age. You start seeing that kind of stool. It can get like little tiny balls in it and really hard to clean up. It's an interesting type of stool. So I can't describe it. I was trying to figure out the right word. All I could think of was little balls. You wipe it up and the little balls just keep running around on the skin. It's quite interesting. Anyway, the formula-fed babies, they are a little bit more challenging because they do have an odor. That's when daddy might gag, mama might gag. Nurses don't gag. But yeah, it's soft, pale yellow, and it, depending on what the formula is, it can get kind of not pleasant to smell. It can be more irritating to the skin as well. So it's important to keep their skins clean and dry. And that, again, passes within about 4 days of age. Kidneys have been functioning, right? What's the kidney functioning been doing all this time? It's been providing amniotic fluid. So it's been functioning since about 4 months of gestation. The glomerular filtration rate is low, but it's been working. The tubules are short and narrow. The initial urine that you see may have a little brick dust appearance to it at first, but it clears as the babies drink more fluid, drink more milk. They should void within 12 to 24 hours of birth, and they void 2 to 6 times the first 2 days, and then they increase to about 25 times a day. So they become quite the kidneys start working really quite well. 40% of the body weight is extracellular fluid in the newborn. So what you'll see in a newborn weight is they'll lose about 10% of the weight. If they weighed 7 pounds, they're going to lose about 7 ounces before they start gaining weight again, and that's fluid that's coming out. So if you have an 8-pounder, they're going to lose about 8 ounces. Then they'll start gaining again. It's kind of a guideline. They say 10% of the 10% weight loss after birth before they gain is normal, and they excrete about 20% of their total body weight each day until they can take in enough. Okay, they are very immune, very susceptible to infection. They don't have a strong immune system. What they do have is acquired from the mother. And the different immunoglobulins, IgG, IgM, and IgA, we'll talk about those, I think, on the next slide. The IgGs cross the placenta, and they do provide immunity against bacterial toxins that last from weeks to months. IgM elevation in a baby's immune system says that baby was exposed to torch infections of some sort. We'll talk about those in a minute. And IgA, those immunities protect the respiratory and GI tract. and they are present in colostrum. So that's when you hear that breastfed babies have a stronger immune system. This is specifically what that is referring to. Those babies are getting IgA, and they have less risk for getting infection in their respiratory tree and their GI tract because of that protection provided by IgAs. In your physical assessment, be systemic in collecting data and performing your physical exam. Work head to toe. Come up with your own way to do your assessment the same way, baby to baby to baby, because that way you won't forget to do something. If you do, you just go back and get it, but you get more efficient if you have a system. You'll want to review the chart for data related to the history of the pregnancy itself. What complications did this baby have? What prenatal situations did it have to deal with? What was the labor and delivery like? Was it a C-section baby, which would make it a little more prone to respiratory problems than a vaginal delivery? Would they have decent Apgar scores, or were the Apgar scores low initially and then had to be helped to get to a stronger Apgar score? All those things will tell you what this baby had to do before it even came into your site. So that helps understand what that baby needs. And as I said, identify the infant, of course. We always do patient ID, and then perform your assessment in a head-to-toe, cephalocaudal, not toe, head to butt, but cephalocaudal manner. Vital signs, the respiratory rate is 30 to 60 a minute. They breathe a little faster, but over 60 is when the concerns should start. The heart rate remains that kind of normal that you're used to as far as the fetal monitoring. It doesn't change much initially. They're still going to be the average of 120 to 160, settle down a little bit when they're sleeping. It'll go higher when they're crying. If it's over 180 or less than 100, that's a concern. We need to do more follow-up on. I'd repeat the vitals, check it again, and then make sure. Temperature should be a normal temperature that we're used to seeing. And the blood pressures run low, 80 over 45 at birth. They'll range 80 to 60 over 45 to 40. The blood pressure is going to be kind of low. The weight, it is what it is. Average babies weigh about 3,400 grams, which is full term. 2,500, that's about 5 pounds something, and your 4,000 is about a 9-pounder. So those are your ranges. But pay attention if you have an extremely small or extremely large baby, you know right away you have complications or potential risk factors to look for. The length is pretty average, 18 to 22 inches. Head and chest circumference. The head should be about 2 centimeters larger than the chest in general. Normal skin color should be pink. Acrocyanosis, do you know what that is? Acrocyanosis is a little bit of cyanosis in the hands and the feet, very normal. Vernix is that white substance that's very sticky, and it's okay to just leave it on there. And jaundice after 24 hours. They're going to have some jaundice. It shouldn't get severe, but so we do have to watch for that. Abnormal if they're pale and dusky and they have bluish lips, cyanosis around their lips. Dusky eyes, you know, you'd see it around the eyelids. The jaundice before 24 hours, that means that baby's has a liver that's being forced to work harder than it should initially, so there's a potential problem. And then meconium staining, which is just the yellowing. If they've been in the exposed to meconium stained fluid, it's going to be a yellow staining on their skin. Okay, their muscle tone, they should be strong. They can get very strong. It's interesting. They can pull the stethoscope away from them, their heart. They can be very very fun to take care of because they respond and either they like it or they don't like it. Their posture will have that called the fencing posture, and look in your book for a picture of that. I believe there'll be one in there. But that's where if the right hand is elevated up, the left leg's going to be out, and then if you switch hands, it's going to go just the opposite. It's pretty cool to play with them to make them switch like that. But their movement should be symmetrical. If the right arm can go out all the way, the left arm should be able to. It just probably won't at the same time. Abnormal is if they're very floppy or rigid and they're weak. They can't move one side or the other as well as the other. There's something's got to be checked out there. What's normal on their skin is a slight thickening, unless they're born real premature, and it's going to be the thin gelatinous kind. Superficial cracking, especially as they get post-dates, their skin will crack even more. They'll have a small amount of lanugo, which is the little hair, and you'll see that mainly on the shoulders. That lanugo starts to be there during a premature period of time, and then it goes away. And so it should be in the going away phase if they're full term. As you see on the abnormal, they may have no lanugo, which means they're so premature they didn't even develop it yet, or they have a lot of lanugo. There's preterms enough that it hasn't started to go away. So you'll see either no hair on their back or shoulders or a lot of hair. Milia are just little white dots on their nose. That's normal. Erythema toxicum, just little red spots here and there. It's on their skin. It's not a problem. It's just transition things. Birthmarks. Check the baby over for what different birthmarks you can see. And we'll see pictures of some of these in the next coming slides. Abnormal would be, of course, open lesions, and those can happen due to a herpes or accidental trauma at delivery, perhaps a scalpel if it was a C-section. So just look for any of those types of, just evaluate the skin really well. There's the milia on the nose. You see them there? Little milia. Erythema, this is very common, not unusual. It's just a little redness. No, they don't have the chicken pox. They're just a little redness. It does have little bumps too. Mongolian spots, these are more common in African American babies, Asian babies, Hispanic babies. They just have it looks like a bruise. It's not a bruise. It's a Mongolian spot. The parents are not abusing the child. Especially since it just got here. But point being, evaluate. Find out what's on there normally. Okay, that's our job. They shouldn't have tattoos, okay? All right, stork bites. Here they are. Port wine stain and strawberry marks. This is a little stork bite. Those will fade with time. They may not completely go away, but they will fade. Port wine mark, that may be precancerous. Those do deserve closer watching. And this little strawberry mark, that is not, it's not a horrible thing. It's just people don't like them, and they may at some point be able to surgically remove those. But do your evaluation, assess them. The head should be round and maybe symmetrical, and I'm saying maybe because it depends on how it was presenting through the vaginal canal, especially if it was a vaginal delivery. Because if the head was turned a little cattywampus, it may not be symmetrically molded, if you understand what I mean. But it should be, you should be able to palpate it and feel that the bones itself are round. Molding is the tissue. It's not, and it's some of the bone, but it's mainly a tissue that will mold to fit through that mom's vaginal area. Caput, cecidinum, and I can hardly say it. We just call it caput, and that's some of the caput is the molding on top of the baby's head that is smushy. You can feel the scalp underneath it. Cephalohematoma, that is where they actually have a hematoma under the skin. And the way you tell the difference between these two is caput is not limited to one side of the suture line or the other. It'll happen regardless of where the suture line is. Cephalohematomas will not cross past the suture line because it's limited to one side of the head, because it's blood effusion out from one side and the bone kept it on one side, the suture line actually. And then we evaluate the anterior and posterior fontanelles for their size and whether or not they're sunken in or bulging out, which either one would be not good. There's your bulging or sunken fontanelle. They should be fairly smooth and just present. You should be able to feel them. Abnormal would be a very small head or a very large head. And we do head circumference measurements on these babies, so that tape measure would tell us what's abnormally large or small. And also your eyes, just feeling ahead after you've felt newborn babies, you're like, ew, this is not right. And then overriding or separated sutures would be a problem if you feel those sutures actually crossing over each other. That could not. And this is caput, as I was mentioning. You see it just they look like little cone heads. Sometimes the caput's up here. It depends on how the baby, what part of the baby was headed out first. And this part was headed out first, so the head molded so it would fit through the mom's vagina. As you see, caput crosses the suture line. There's a suture line there. It's not limited to one side because it's the soft tissue above the suture that has actually been pushed up. If this were a cephalohematoma, it would have occurred down here, and it can't cross that suture line. It would be limited to one side or the other. Okay, let's check the eyes. Normal is a slate gray color. They get their full color, I think by 6 months is what I've heard, is when they'll have their final color. Crossed eyes is very normal. Can you imagine trying to see after you've been in where it's been dark? All of a sudden you're like, what in the world? Their eyes have no muscle. They've had not having any stimulation to work those muscles to not be crossed. So it's not surprising. They might have little hemorrhages in there, could be edematous, especially the eyelids. Blink reflex, they're just trying to blink and see. They'll look like they're trying to figure life out. What in the world is this? It doesn't matter what it is, like, okay, what's that? And they're just trying to focus. They cannot make tears for a few weeks, okay? So if you see tears, it's not tears. It is, I've never seen tears. I'm trying to imagine a time when I saw water coming out of eyes. I haven't, I can't. Okay, abnormal discharge greater than 2 days after erythromycin. Erythromycin's given, as you know, to prevent eye infections. So if they develop a discharge a couple days later, that needs to be evaluated. And the opacity of the pupils, of course, that could be a potential cataracts in a newborn. The nose and neck. The bilateral patent nose, they are nose breathers, and that should be able to breathe in each side. Way you can check that is to take one finger and occlude one side of the nares, and they should still be able to breathe, and then you do the opposite nares, and that way you can tell if each nares is able to breathe air through it. They have a short, supple neck, and their trachea should be midline. If it's not, you wonder about some kind of a tumor you can't see. And their head is going to lag a little bit. The head neck muscles aren't very developed yet. Abnormal would be the non-patent nose that you've identified by occluding one side and they can't breathe through the other side, or rigid web neck. And the web neck can be a sign of Down syndrome, and it's truly a webbing connecting the neck to the shoulder. Ears, the ear pinna is firm and is the same plane as the eye angle. So you just kind of take your finger and draw an eye between the two. They should be in the same plane. Positive startle reflex, where when you lift up their arms and drop them, they jump. That's normal. The Epstein pearls, I think I have a picture of those coming up here on the gums. They're just little bumps on the gums, very normal. The palate should be intact. You make sure that you put your gloved hand inside and palpate that palate. They might suck the finger. That's a good way to assess if they have a good suck, which is of course important to eating. They may have a sucking blister because, believe it or not, they have been sucking on their hand in there, and they could have sucking blister on their lip, and some mucus is present in the mouth. Abnormal would be ears that are low set, pinna soft, and slow recoil. And these things you'll implement in simulation, I believe, or at least attempt to on our babies in simulation. I don't know how we do that because they're plastic. But the pinna will be soft versus firm. As the more mature that baby gets, the more firm that pinna gets. And it bounces back. When you bend your earlobe, take your hand up to your earlobe, pinch it, put your ear, try to put it in half and let go, it should bounce right back. In an abnormal, the preterm babies, they slowly go back. Might have thrush in the mouth. That's a whitish or type substance in the mouth indicating yeast. Of course, cleft lip or palate, which we're evaluating for. That protrudent tongue, it looks too big for their mouth. That's a potential sign of Down syndrome. And then excessive mucus, where they have a tracheoesophageal fistula, they can't swallow it all. So there's a lot of mucus. It has to come out somewhere. It'll come out through the mouth instead of the swallowing it. Okay, I lost my little. Okay, where's my thing? Sorry, guys. There's Epstein-Pearl. That's very normal. Just bumpy lips. The thorax or the chest should be barrel-shaped, symmetrical, and they may have breast engorgement. Actually, in some babies, even little boys, may have witch's milk. It's all normal. It's hormonal. It's all a hormonal change from mom, and they may have a murmur when they're stressed. Abnormal would be the chest wall is not symmetrical. There's a favor on one side or the other that's larger, and you wonder about tumors or organ being abnormally displaced. The chest that's larger than the head is not normal, and they may have no breast tissue at all. If there's any pus or blood coming out of the breast tissue, that's unhealthy. It needs to be evaluated. Respirations are diaphragmatic and abdominal, and nose breathers, okay? Their breath sounds should be clear and equal bilaterally, and they're going to have transient tachypnea. Abnormal will be your respiratory rates greater than 30, less than 30 or greater than 60. And as we've mentioned before, nasal flaring, retractions, grunting, and you hear water rattling in there when they're breathing. You just hear it. You can hear it in the room. You don't need a stethoscope on some of them. Abdomen should be soft and round. You should be able to feel the liver 1 to 2 centimeters below that costal margin. They're very thin walled, so you might be able to feel that. Bowel sounds should be present, and the umbilical artery should be bluish white with 2 arteries, 1 vein, and you'll check that when you have you're doing that first assessment after birth, looking to make sure it has 2 AV, 2 arteries, 1 vein, because that indicates that the circulation was adequate. An abnormal abdomen would be scaphoid, and I think I added a picture of that, and it's a dip in like the pigeon chest, or a distended abdomen, no bowel sounds. If the umbilicus is jaundiced or meconium stained, less than 3 vessels, or if it's bleeding. Those are all causes to do further investigation. Yeah, here's a scaphoid abdomen. You see how it caves in. And it may indicate a diaphragmatic hernia. Thorough inspection of that spine is really important because spinal deformities can go undetected. The tiny ones can. So when you're evaluating your newborn, turn him or her over on his tummy and take your finger and rub all the way down the spine from the neck all the way down to the butt crack. And even when you're down there, open the skin at the very base of the spine and make sure there's not a tiny hole that is easily missed. You want to make sure that it's intact, the skin is intact all the way down. Babies should have an equal moral or startle reflex, which kind of always makes me feel bad to do it, but we have to know that they have good reflexes. You put their hands up and kind of lift them a little bit, and then when I say lift them, I don't mean an inch. I mean just put those arms up and let them go, and they should startle equally on both arms. The medial skin folds on their thighs should be equal, so when you have them on your tummy, put the legs together, and those little butt folds should be similar in the horizontal plane. They're going to have some leg bowing. That's normal as they've been in utero, bent up for so long. Their arms and legs should be able to fully flex, though. You should be able to get them into a full flex position. And of course, count the fingers and toes. Abnormal would be that abnormal curvature of the spine. As you run your finger down, you feel it go not straight. That could be an abnormal curvature. If you see dimpling down there or hair tufts on the spine, hair tufts could be an indication that there is a spina bifida that's tiny and hard to see under the hair. The unequal moral, where you pull the hands up and you kind of let the startle happen, and one side reacts but the other side doesn't react as well. That could be a problem, and that asymmetry of those little butt folds could be an indication. If they can't flex equally, if they've got more than 10 fingers and toes, of course, if they have any type of fracture, clavicle fracture is the one that comes to my mind as we worry about some of those tough deliveries. Going back up to the hip click on the abnormal, put the baby on the back, and as you pull the legs out straight equally and then together push them up towards bend the knees towards the baby's tummy, and then go outward and come down, flex them outward and then bring them back to straight down. You may hear a hip click on a baby that's got a problem there. There's your polydactyly and syndactyly. These are merged together. These are easily fixed. They would be able to separate that quite well. And this, I'm not sure how they would do that. Probably remove that. I don't know. We let the surgeons decide that, but they could easily remove if the parents even wanted to do that, because it's not going to hurt the baby lifetime. It's just not a normal amount of fingers. The fractured clavicle, as I mentioned, you see that here. That can happen with those difficult deliveries. The shoulder dystocia, a large baby is the one at risk for that. Make sure we check these clavicles really well. And what you'll do is put your hand, one hand right here on the clavicle, and like right here, and with the other, you'll move the arm up and down. This should not click. If you have a fracture, if you put your finger here and put this arm up and down, you're going to feel a click. Okay, so that's indicating that could be a fracture, and they'd want to probably x-ray that. Here's the unequal moral or startle reflex, and it's an Erb's palsy going on. Do you see that there? He just can't, that whole side is impinged, a nerve problem. You can tell by looking at that little arm. It's backwards instead of forwards. It's many reasons that could have happened. Forceps delivery, difficult shoulder delivery, many different things can happen. The genitalia on the female, the normal would be red and swollen, and what you'll notice is that the labia majora will completely cover the minora on a full-term infant. Preterm, that labia majora is going to be widely separated. It's not going to completely cover the minora. Okay, and this is all part of the evaluation that you'll do. It's our newborn assessment sheet that we have. The clitoris will be enlarged as it's swollen. They often have a milky white mucoid discharge coming from the vaginal area. You may see a hymenal tag. They should have a patent anus, and we used to do that first temperature used to be done via rectal thermometer so that we could confirm patent anus, but they don't do that any longer. Now they just wait for that first stool, which would indicate it's patent, and pay attention to when they finally poop. Here's the abnormal again, where the labia majora are smaller than the minora. The more minora are protruding downward right there, and imperforate anus, of course. The males, normal would be testicles would be descended. Urethral opening is centered in the distal portion of the penis. It is not epi or hypospadias, which I think there's a picture in here. The foreskin should cover the glans penis, and they should have patent anus as well. And you can feel the testicles. You feel the scrotum, and it'll feel like a little marble in there. Undescended testicles could eventually need surgery, but that's up to those pediatricians to decide. Here's your hypospadias, it's down below the urethral openings at the bottom. Epispadias, the urethral opening is towards the top. Okay? That's a whole thing as I'm looking. This whole thing is epispadias. You see that? That whole thing. Okay. Then there's doing the Dubowitz or Ballard gestational age assessment, which is a really good way to get familiar with evaluating a baby and getting comfortable with them. It's a checklist. You go right down this checklist and evaluate. It takes a while to feel like you know what you're talking about, but with practice you get better. What you end up deciding is if the baby is as the gestational age they're supposed to be. Now, in today's world, with ultrasounds being done all the time, we very rarely do not know how many weeks a newborn really is, where we have those dates pretty darn firmed up by the time they're in there. But it's still important to do this assessment to see if they're falling off that maturity scale in spite of what we know they should be. So the physical maturity, we're looking at that skin, the cracking of the skin, how smooth it is, how well can you see the blood vessels through it. All the things that we've talked about, the lanugo, the amount of hair, plantar crease, do they have that crease that indicates that the hands have had time to develop the creasing? The breast tissue, the ears, how well they bounce back, genitalia, the labia minora, majorita factor that we talked about. Neuromuscular, they check, these are fun to do, so hopefully you'll have a chance to do these sometime. The posture of the baby, arm recoil, pull the arms down, they should ping right back up. Maybe not real quick, but they should go back up. Wrist flexion, you take your fingers, take your hand, your third fingers, and try to put that tip of your third finger on your inside of your wrist. You can't do it, but in a full-term newborn, you can put that finger on their wrist from the inside. It's pretty, I mean, it bends it right over, right? You just flop it right over. When you're new at doing that, you're afraid to break them, but so then the experienced nurse comes along and just puts the hand down and says, zip. And it's basic. I don't know, I'll show you in class if you want to see it. Of course, I can't do it, I'm old. But anyway, popliteal angle, what is the angle of that popliteal angle down at the leg? And the scarf sign, that's where, how far over can one draw the baby's arm over across the chest? Can you get the elbow to the side of the chest wall only, or can you pull it all the way over to the left breast practically, or right breast, depending on which side you're coming from? I'm practicing with my right hand here. And then heel to ear extension, that's again a leg thing. You pull that leg up, keep it straight and pull it up to the ear. How well does it do? All those things are hard to explain. You really just have to play with the baby and do it, and it's fun. Their vision is 20/150, and they can see approximately 10 to 12 inches from their eyes. They do prefer the human face. They like black and white best, and they do perceive light. So when parents are planning for bringing a baby home, they always bring these really colorful things. Well, it's better just stick with black and white for a while, because that's what the baby can see. It won't hurt to do colors, but black and white is fascinating to newborns. And the other thing, I saw a study done once where they had shown a baby, it's just drawings of a face drawn with just a circle and then two eyes, a nose, and a mouth, like normal. And the baby would look at that picture, really like try to figure that one out. But when they do a circle that had a mixing up of the two eyes, nose, and a mouth, in other words, they were not lined up like a face, two eyes, nose, and a mouth, baby didn't even want to look at it. They were focused on the one that looked like a face, didn't care about the ones that had no same amount of things on it, but it didn't look like a face. Pretty fascinating. They will startle with noise. They turn toward the sound. Touch is well developed. They do experience pain, of course. You'll know that when you give a hepatitis B shot or the vitamin K shot. They don't like it. The taste gets differentiated already between 1 and 2 days, and they will turn their head away from odor. Interesting. The Desmond's pearls of reactivity and Brazelton sleep-wake states are behavioral assessments. Here's Desmond's pearls of reactivity, and there are 3 phases of reactivity. The first period is immediately after birth, and it lasts about 15 to 30 minutes. So as soon as the baby is out, they're crying, vigorous activity. They're looking around. They're really just, you know, trying to figure out where they are. They're sucking, trying to connect with something familiar. And it is a great time for the parent and infant to have interaction, because that baby is so awake and alert in that first period of reactivity. Then they go into a period of inactivity that lasts anywhere from 2 to 4 hours. During this period of time, the infant is harder to arouse. They go into a deep sleep state. I mean, they have done a lot of work, and now they're just like crashed, okay? Their respiratory rate and heart rate will decrease to a baseline that you would like to see, and then the temperature may drop down but still stay within a normal range, and you'll start to hear bowel sounds. Now imagine when with the mom who wants to breastfeed, do you see why it's important that she breastfeeds right after delivery and doesn't wait? Because if they wait, they get it if the baby's in this period of inactivity and she's trying to breastfeed for the first time, baby wants to sleep, she wants to feed the baby, it's not going to work. So it's essential that that breastfeeding mom gets that baby within that first hour, within minutes of birth, to nurse. Take advantage of that reactivity. So once they get into the inactivity, 2 to 4 hours, and then they go back to a second period of reactivity, which is about 4 to 6 hours of age. They start to wake up. They're pretty much physically stabilized. They need to be watched for gagging and more mucus as they're just settling in. Just see what their resting vital signs are. And the bowel sounds increase, and they may pass their first meconium at this time. And this is a time to get that second breastfeeding in, or the first bottle feeding. Okay. The neuromuscular system is able to sense and respond to all experiences. Assessment provides information about the neurological status and enables early identification of problems. So we really watch these babies for how they respond to their surroundings and to noises and to anything, to touch. Survival and safety reflexes are in place. They root, which means they try to eat. They sneeze, they gag, they suck, they swallow, they cough, they blink, they cry, they startle. All those are very normal behaviors that are very reassuring. The rooting reflex, as I mentioned, is the feeding one. It diminishes by about 6 months and disappears by 1 year. And if they don't root around and don't appear interested in eating, it could be a problem with CNS depression or an immature central nervous system due to prematurity. The sucking reflex is the one that needs to be, hopefully they can suck. We can check that with our finger in their mouth, our gloved finger in their mouth. And sucking becomes voluntary by 6 months. And again, abnormal would be central nervous system depression or birth trauma, which causes central nervous system damage. Swallowing, if they're preterm, they can't swallow really well. You will have preterm babies being evaluated for their ability to suck and swallow. They're actually testing things that they do to see if they can suck and swallow. But a baby that can suck and swallow has a healthy CNS. Their grasp, they're going to grab onto your stethoscope. They're going to hold your finger. They could hold dad's finger. Those are all normal, healthy grasp reflexes, and it is a very social behavior. It's really cool to see the dad, honey, look, he's holding onto my finger. It's a really neat way for dads to feel that bonding to their child. You just touch their palm and they'll grasp it, and even their toes will try to wrap around. The moral or startle reflex, that's postural. With sudden position change, the extremities will extend bilaterally and the thumb and forefinger form a C, and they just jump right out. And it diminishes by 4 months and disappears by 6 months. And again, if it's abnormal, you may consider the possibility of the Erb's palsy, fractured clavicle, or central nervous system injury. The fencing I mentioned, that's where the relaxed infant, the head's on one side, extremities extend on the turn side with opposite extremities being flexed. So they go back and forth. You turn the head, they'll change which extremities are flexed and which ones are extended. It's pretty fun. It's fun to play with these babies. You might not be able to get that immediately after birth, but up in the postpartum area you should. Okay, another reflex is the startle reflex, and I've used the word moro and startle interchangeably. They both have very similar reasons for being, but the moro reflex is one more of extension of the extremities. They'll move outward, whereas the startle reflex, they'll pull inward. It's more of a protective. It occurs with the same types of stimuli, okay? But the moro reflex is when they extend outward, and the startle is when they pull their extremities inward in response to it. And they're both normal reflexes. The sneeze is protective, of course. It's involuntary, and it acts to clear out the nasal passages. So the Babinski has no category, but it's just there. It's a positive response that is expected, and what you do is you stroke one side of the foot and the toes will go out and extend. So if you ever are around a baby, a newborn, before a year old, or even the younger the better, just stroke one side of the foot and the toes will go out and extend. Now that is healthy in a baby, not healthy when they're after a year old, because it does indicate CNS damage. In fact, in adults that have had central nervous system injury, they have the return of the Babinski reflex, and it's one of the signs of really that adult's CNS is not going to come back. The Apgar score is a measurement of 5 different things that we assess, and it is the way that we determine if the newborn needs resuscitation at birth. That is the purpose of the Apgar score, to determine the newborn's need for resuscitation maneuvers. It's a measurement of the heart rate, the respiratory rate, their muscle tone, their reflex irritability, and their skin color. The highest score they can get is a 10. It's rare to get a 10, but that is the highest possible score. And it's performed at 1 minute of age and 5 minutes of age. So it's the first test that baby has to take. And if the Apgar score is 7 or better, they do not need special resuscitation. They just need supportive at 1 minute. We're talking about the 1 minute. The 1 minute Apgar score is the one that tells us what resuscitation is needed. So if it's 7 or better, 8 or better, I'm going to say 8 or better, because 7 I'm going to watch really closely, but 8 or higher, we just keep watching them, make sure that they are continuing to clear their nasal passages and cough and sneeze and do all those things they're supposed to do. If it's 4, 5, 6, or 7, then I'm going to stimulate that baby. That baby needs a little bit of stimulation to make sure it's crying well, that we can get that Apgar to go up, because we like to see those Apgar scores 8 or higher at that 1 minute. At 5 minutes, we reassess the baby for Apgar score, and the purpose of that one is to see if our resuscitation efforts, if they were needed, are successful. So if you have a 1 minute Apgar score of 8 and a 5 minute Apgar score of 9, then our resuscitation effort was successful. What would our effort be on a score of 8 at 1 minute? Keeping the baby warm, dry, keep watching it, keep stimulating it if we need to. That's it. Mainly keep them warm and dry. And it should naturally increase up to a 9, get better by a point. And the thing that usually gets better is the skin color, okay? The other 4 parameters usually are still good. Start out good and stay good. Now, if I have a 1 minute score of 7, I'm going to definitely do the keeping it warm and dry, and I may do a little oxygen blow by just to have it sitting there so he's getting in more oxygen just from not a mask, nothing that goes on the baby. It's just there near the baby so that his immediate environment has more oxygen in it, because my goal is to get that over 8. Okay. If your baby has a 1 minute Apgar of 1, 2, 3, definitely needs resuscitation, you would have the NICU team, you'd call them, get them down there. You're supporting that respiration and the cardiovascular, and you may be doing CPR. I don't know, but the goal is to get that 5 minute Apgar over 8. And if you have a poor 1 minute but a good 5 minute, the long-term outcome for that child should be pretty good. But if you have a low 1 minute and you can't get that 5 minute more than 8, there could be issues. So just know the Apgar score is created by Virginia Apgar, and its usefulness is in telling us not just how healthy the baby is, but does this baby need resuscitation of any sort, special other than supporting it and keeping it warm and dry. The delivery room care priority is to maintain adequate airway in the newborn. Make sure they can breathe. You might need to use that bulb suction and suction out. You never put that bulb toward the back of the throat. Put it toward the cheek, okay, inside the mouth toward one cheek or the other. You don't want to aim it towards the direct back of the throat, because you could cause damage to that throat tissue. We want to prevent that cold stress. So remember how we do that? Warm and dry, warm and dry, warm and dry. Keep that baby safe. Keep them safely in the mama's arms, preferably. And if the mama's busy with her own issues, because maybe the mom's having problems, we keep the baby safe in the warmer in the room. Okay. If there's a big complication with the mom, we'd get the nursery to come and get the baby out of the room if we have mom in really severe situation. But we have to note the time of the complete delivery. So if the head starts delivering at 12:02 and the baby's body doesn't come out till 12:03, time of delivery is 12:03. All right. It's when the delivery is complete. Suction out the mouth and the nose, assess respiratory status, clamp and cut the cord. These are pretty much the provider will be doing that, but if you do your own delivery for some reason, you will be doing these things. Suction out the mouth and nose before the body comes out. Head comes out, suction out mouth and nose with that bulb. Then deliver the baby, you clamp and cut the cord, and then you're assessing respiratory status. Placental cord blood sample for RH if the moms are if the mom is RH negative, it's essential that we get cord blood to send to lab to see if the baby is RH negative or if they're RH positive. We may have to do cord gases on that initial sample if we're worried about the oxygenation of the baby at the end of delivery. We have really bad decelerations or something that causes us concern. We'll do that. It's not routine, but it would be done in anyone we're concerned about loss of oxygenation at the end. Again, Apgar scoring is done at 1 minute and 5 minutes. We like to see it increase at least by a point. It means we're headed in the right direction. Babies in the radiant warmer, skin to skin with mom, dried to conserve heat, temperature taken. Temperature can be taken while mom's holding the baby, right? We can listen to heart and lungs while mom's holding the baby. It says place the baby in Trendelenburg to facilitate drainage of secretions, but really let's just let the mom hold the baby and let the baby cry. Well, he's not going to cry if mom is holding him, but brief physical assessment. We're not going to do that whole assessment we just talked about. We're not going through all that. We're just doing our brief assessment, make sure the baby's stable, get it identified with the ID bands. We put those on before the baby leaves the room. The baby gets 2 ID bands, the mama gets 1, and the daddy gets 1. Or the significant other, if daddy's not able to be there for whatever reason, it might be the grandmother, whoever. There are 2 ID bands there are 4 ID bands total. 2 go on the baby, 1 goes on the mom, and the 4th one goes on whoever the mom decides. If for any reason that there is absolutely no one else for that 4th band to go on, then the mom gets 2 bands. We put both of them on her, but all 4 bands are accounted for. Of course, we get the weight and the length. Once the baby's stable, parental interaction and first breastfeeding is encouraged. And of course, now we're kind of, as long as the baby's stable, it stays on mama anyway. And we can do this. We can do this stuff on the mama's tummy. We really can. We can even get footprints on there. So just be flexible in how we approach that part. We would transfer the baby and the mama to postpartum, usually, hopefully together. Be admitted to the room together, postpartum room. We don't really, a lot of places don't even have nurseries now, but whatever the protocol is in that hospital, before the labor and delivery nurse leaves the baby and the mama, the postpartum nurse and the labor and delivery nurse will double check those bands, ID bands, to make sure they all match. Because that postpartum nurse wants those bands to match, and if they don't, it's this person's fault. She's not going to be left with the problem. It's like, why did you bring me a baby with bands that don't match? So we've got to make sure they match. The nurse up on the postpartum unit would get the vital signs every 30 minutes for a couple hours and assess that baby's general appearance and perform that complete physical assessment as soon as her time allows. Nursery care, monitor infant at all times for stability. And again, most of our babies, I think anymore, are kept at mama's bedside, so we have to be in that room a lot. Vitamin K and erythromycin, that's given in the labor and delivery area most places. Evaluate the cord. Some places put triple dye on it. Follow protocol basically, but you're going to evaluate that cord and make sure parents are interacting with their baby in a healthy manner. Just watch. Are they talking to the baby? Do they ignore the baby? Every time you go in the room, is the baby in the crib and the mom's on their phone or doing Facebook or doing anything but being with the baby? Watch for those behaviors. Vital signs are done every shift. Keep the bulb syringe in the crib just in case you need it. We get minimal bathing after that initial bath. The babies are not dirty, good heavens. They're not playing out in the mud. And check on that cord and remove the clamp before the baby goes home. If it's discharged, if it's dry enough, get the clamp off of it. That'll fall off with care by about a couple weeks. If the circumcision is present, monitor for bleeding and apply Vaseline ointment to prevent trauma from the diaper. My goodness, could you imagine putting a diaper on that? That little penis is bleeding a little bit and sticks to the diaper or the urine. Ooh, no, put Vaseline. Usually they have it on a little gauze, Vaseline petroleum gauze. We get the PKU after the first feeding of breast milk or formula. It's a state mandated screening test, usually done at discharge. And it's not just the PKU anymore. There are, I don't even know, I can't keep up. There are many, many different types of protein and nutritional deficiencies that they pick up with those. So it's 6 circles on a pad of paper, not a pad of paper, it's a card. And 6 circles need to get filled perfectly with blood. From heel sticks from the baby, poke the heel and do that. So if you get a chance to do that, it's a good experience. Daily planning, watch for oxygenation, thermoregulation, hydration, elimination, and hygiene. Watch for signs of lethargy, of fever, vomiting, diarrhea, and loss of appetite. Those are your things that we are going to watch out for while our babies are in our care, and are the things that we need to teach our parents to watch for when they take the baby home. Here's where they may lose up to 10% of their birth weight the first few days. So, and I just would always tell parents for every pound they're going to lose an ounce. So if they're 8 pounds, they're going to lose about 8 ounces. It averages out to be about that. So you don't have to memorize these. When they're eating, evaluate, can they suck, swallow? Do they have an adequate gag reflex? They'll be on I&O for a while. And how do you check a breastfeeding baby? You do that by checking the output. If they're peeing good, their intake's fine. If there's a concern, then they have to do other things to further evaluate it, and they may put the baby on formula to supplement for a bit. Urine output should be about 1 cc per kilogram per hour, basically 3 or 4 diapers a day until they go home, and then it's like 100 billion. And they may be fed by breast or bottle. All right, 100 billion is an exaggeration, but you get the drift. Breastfeeding may start in the delivery room. If they don't eat well, it could be because mom got narcotic in labor, just very sleepy, a difficult delivery. Baby could just have a headache. I mean, I always want to give babies Tylenol when they're born. I'm like, you got to have a headache from what you just been through. So the best we do is just assist the mom and help get them as comfortable as possible. Teach the mom about the root reflex and nipple position. They have lactation specialists at most centers I've been at, which is really a blessing because it's an excellent resource for moms that are having any trouble at all. Even if they're not having trouble, it's nice to have lactation specialists come by and make sure they're doing okay. Length is usually 3 to 5 minutes, up to 10, and frequency every 2 to 3 hours on demand. I had a rule, don't ever wake a sleeping baby, but if they're born preterm and they're very tiny, they may need to be awakened to eat. But in a healthy newborn, if it's sleeping, it's not hungry. That's how I felt. Okay. Bottle feeding, again, we want to help the mom to be in a comfortable position. Remember the size of that tummy. It says approximately 30 milliliters and then burp. But if they slow down, burp them and start over. Start them again. They usually eat every 3 to 4 hours on demand. They're spread out a little farther apart than breastfeeding moms because they have 30 milliliters to eat all at once, whereas the breastfeeding moms have to build up to that amount, that quantity. They don't have that quantity present in their breast. They need to be taught about the breast bottle feeding moms, taught about that root reflex, how to position the bottle to prevent swallowing air. You want milk in the nipple. You don't want air in that nipple, so the bottle has to be held up, angled to that level. And then burping. Of course, we've got to burp the babies. Anticipatory guidance with feeding. There's stages of lactation, starting with colostrum, going into the actually making milk, building up to the quantity that baby is needing. Adequate fluid guideline is 6 to 10 wet diapers a day. So as long as you're changing wet diapers between that, you're making enough milk. Do you plan to do scheduled feedings or do you plan to do on demand? Let the moms figure that out. And then they also need to learn how to express and store their milk, especially if they're going back to work or want to make sure they have breast milk for a baby while they and her husband go out for a date. Weaning, do you plan to wean right away before you go back to work, or is that going to be a gradual over a year or so? Formula, how to sterilize those bottles, the schedule to do, amount to feed, and do not prop the bottle and walk away. You got to be with that baby. If they start choking and gagging and that bottle's propped in their mouth, they can't do anything about it other than choke and gag. Bathing and shampooing would be other items to go through with them at home. How to take care of that cord, what to do if the baby's crying. If a baby is crying uncontrollably, I mentioned this at class, you know, what is the parent, whoever's with the baby, because it could be the dad, what do you do in the minute when you're frustrated? What are the measures to take to deal with that in the minute so that you can then deal with it in a healthy manner in the longer moment, okay? How to diaper, it's kind of fun to watch the first diaper changes, well child checkups, developmental milestones. Of course, they're not going to learn all this before they go home, but teach what you can. There's pamphlets and reading material they can go home with. Of course, there's YouTube now too. Everybody does YouTube. Safety, suffocation, how to avoid that. Don't put stuffed animals in the crib. The baby doesn't even know they're there, and they just provide a potential suffocation risk factor. They sleep on their back now. We used to do propping this way and that, but it's back sleeping to prevent SIDS. Again, long-term and more, this is going to happen more likely in the pediatrician's office with how to prevent falls and poisoning, accidental poisoning, that aspiration that we mentioned with the bottles, burns, you know, stove, you know, being around a hot stove, motor vehicle accidents, safety car seats, how to be a safe parent. Keep your baby as safe as possible. All right, and that's it at the moment. And we're going to watch a video in class about the baby, because I didn't play it last week. We didn't have time, but I'd still like to show you the baby that nurses without, it figures it out. It's crawling, the breastfeeding crawl. So anyway, that's it for this one. Going to do complications next.